What I'm going to present to you is something that I think is a little unusual and that you should be doubters, at least to begin with, but I hope to show you where I think we're succeeding. I was certainly a doubter when it came to this. So let me jump in here. I am Ari Melmed. Sadly, I have no conflict of interest to disclose. I am an emergency physician. I work for Colorado Permanente Medical Group, so Kaiser, Colorado. Let me start with this. How many of you, since this talk started, have engaged in a video chat? Raise your hands. And how many of you have sent at least one text message? Come on, be honest. Okay, we'll come back to that. So the problem we're trying to solve is this. So we're an HMO, we're responsible for all the medical costs. And like any healthcare organization, we struggle with access. Patients want to get in a timely manner, and when they can't get in a timely manner, we find them using more expensive on-demand venues, emergency departments, and so forth. So we needed to build something that was going to help bridge that gap. Prior to launching chat, we had several virtual care options in place. And people don't talk about it much, but email is virtual care. And we send millions of emails back and forth with our providers. The resolution rate for email is pretty good. We have scheduled telephone visits, non-scheduled telephone visits, what we call e-visits, which are protocol-based nurse visits, and of course video. It doesn't show up very well, but we did 300 video. So with all the time and effort that we spent on video, we really weren't getting very much with it. And these were very successful in terms of their resolution rates and how patients felt about them. So again, what we decided we needed to provide was something that was going to be on demand. It was going to be available right away. People didn't have to waste a lot of time scheduling or planning for it. And it needed to have a high rate of resolution. We wanted to put people on who were going to be able to solve the problems that patients were coming to us with. So we considered putting nurses on, we considered mid-level providers, and we decided at least to start with physicians. Yesterday, David Lamb in this room gave a great talk about build it or buy it, and we decided to buy it. So we contracted with SiriusMD. They're presenting here. An established entity, they have a secure HIPAA-compliant chat mechanism. They've got multiple other users and hundreds of thousands, I'm not sure what the number is, of previous users. So we knew we were sort of buying into something that was going to be pretty robust. The other thing I'd add actually to the whole buy or build is have a relationship with your vendor where you can tweak also, because you never just buy something off the shelf and use it. We have these guys working every week. We've got a list of changes that we need to make. So let me just jump into what it is and how we do it. So they white labeled this for us, so it looks to the Kaiser member like they're still in Kaiser. So they go to kp.org and they log in. So that's our user verification, so we know who it is that's chatting with us. And then all they have to do, where am I, is just click chat with the doc. Forget making a phone call to book an appointment for 3 days from now. Forget waiting in the waiting room in the emergency department for 3 hours. They don't have to do so much as shift their position in a chair, and they're in chatting with the physician. And they're taken, oops, where am I?
Just over here.
There we go. They're taken to the SiriusMD website. Again, to them it looks like they're still on kp.org. And you can see there's just a chat mechanism. It looks like any other chat that you would think of. The member sends a message, we send a message back, we can upload photos. First thing I did, by the way, is disable the video visit option because I was going to tie down my provider, so I'll come back to why. So we staffed this with emergency medicine docs and family medicine docs. We needed generalists. We needed folks who were going to be able to handle everything. So internal medicine, trauma, toxicology, pediatrics, psych, OB. We didn't know what was going to come in, and so we needed folks who were going to be able to take everything. The docs are set up to work from home, which is a huge crowd pleaser for the physicians. We are available 8 a.m. to 10 p.m. 7 days a week, and there's no copay. This is absolutely free to the member. And of course, the physicians, have access to the patient's EHR. And this is kind of the secret sauce. This is how we Kaiserize the service. And it's critical for us to be able to have the doc looking at the past medical history. We feel like to outsource this, and we considered outsourcing to other providers, but we decided that we wanted to use our own, and we wanted to make sure that the docs who were providing this knew that the patient had just been cathed 6 months before and it was negative. They knew that they had a negative, CT of the abdomen 2 weeks ago or what have you. So the way it works is the physician will chat with the patient. They'll write a little summary, cut and paste it into the EHR. Of course, you can send that to the patient's primary care team. You can send it to the specialists, surgeons, whomever. Order medications. We can order and review lab results for the members. In our integrated systems, we can even put in referrals for folks. So we sort of became the shortcut to accessing the system and interacting with it. We also set it up to have backup from our telephone medicine center. So the telephone medicine center is staffed by emergency physicians. And so if somebody starts chatting about chest pain or melanin or syncope or something, we just escalate it straight away. We've got their phone number. We say, hey, I'm going to have a physician call you. I'm worried about what you're telling me. So we don't try to get into very high-risk situations. So we weren't sure how it was going to go. We weren't sure what the response was going to be. And when you think about, this is probably true of all virtual care. You've got 3 different entities that need to buy in. The patient needs to feel like their needs are understood, that they're transmitting something that's being heard, and that they're getting reliable information. The physician needs to feel like they're getting reliable information, that they can assess the patient and make a professional recommendation. And of course, we've got the payers who need to feel like, okay, this is a worthwhile interaction to have. With us, with Kaiser, the payers not in our way, and you've just got the docs and patients who need to agree on this. And I gotta say, when Justin Chang, one of our VPs, came to me and said, we should do this, my first 4 words were, I don't buy it. Like, I didn't think that we would get the acceptance. But amazingly, it seems to be working. Patient responses have started to come in, and we're surveying folks, and we're getting every day, we get people telling us, better than WebMD, super fast, thanks again, this is wonderful, we love this system. It's better than email, coolest thing I've experienced in healthcare. Wait for it. I mean, this is like music to our ears right now, because like everybody else, we're worried about patient sat. We're struggling a little bit with that. The volume of this has been taken right off, and this is a soft launch. We did not advertise this until that day. So this was just people finding it on the website. And they found it, they would come back to it, and you can see the trend line. The satisfaction, as I said, is very high. Top box is running, high 70s, 80%. Likelihood to recommend, again, 70s, 80%. Just a few other curious stats. 2/3 of women, I don't know why. Crowdsource that one, let me know. Our age distribution was also a little bit of a surprise. We thought it would be a little younger, and I think when we moved to mobile, and we are not yet on mobile, that we will shift that into the 20s, and we really want to hit folks, in their 20s. Avoidable ED visits and people in their 20s go hand in hand, and so if we can get a hold of those folks, it'd be great. Plus, of course, even just from a member retention perspective, we can get folks signing up in their 20s and 30s because we offer something that others don't. They're likely to stay with us. And we've gotten people in their 80s, which is really amazing. We had one woman who's 89 years old, and she chatted in all caps, and she signed off, "Okay, over now," which is adorable. We're tracking our, the hours at which it comes in and the volume and so forth. We get this huge spike in the morning, and we've had to staff to that. And then during lunchtime, people like to chat again, and then it sort of fades off into the evening. When there's a business case for it, we'd like to say that we offer this 24/7, but it probably isn't right now. Folks just aren't using it that much. Recently, we've been expanding the service, so we figured out that we're actually getting a lot of pediatric chats, and so we brought a pediatrician who's on, and so we shunt pediatric chats to her. And of course, we've got support agents when there's about 17-18% of our members who just are going to need an appointment. We start off with chat, and they just give you certain things that you're not sure you've got enough information. Somebody needs to lay hands on them, and we appoint those folks. So we've got a support agent who's going to do that booking rather than the doctor. We brought clinical pharmacologists on. Some of the questions involve concerns about medication side effects, and can I take this during lactation, and so on and so forth. And the pharmacists actually do a great job of this stuff, better than I would. And then in the bullpen, we've got OBGYN. They're ready to step in, or almost ready to step in, start taking OB-GYN. One of the fascinating things that we found is that the anonymity of this channel tends to drive certain utilization. And so we're getting lots and lots of questions about STIs, birth control, and so forth, behavioral health issues also. So rather than having a family medicine or emergency medicine doc trying to answer questions about the Mirena IUD, like folks would get an OB-GYN to do it. So as I say, behavioral health is a huge one where we absolutely need to get those folks involved in this, and they're not involved yet, but it's on the timeline. And then ED high utilizers are, I think I can say this, our top 50 ED utilizers last year spent $2.5 million. Right, $2.5 million on ED visits. So if we can have somebody dedicated to those 50 people, or even the top 100, and we can bend their utilization by 25-50%, we'd save a huge amount of money. Next up, as I said earlier, is moving to mobile. It allows us to have push notifications, capture folks who are dropping off, and of course go to younger folks. And then one thing we're setting up, which is going to be, we're going to have work site pods for some of our bigger employer groups, where there are some available biometrics, and we're going to try to be selective about exactly what we have in terms of those biometrics, and try to focus on things that actually help clinicians make a decision as opposed to sort of the next shiny thing. One thing we struggle with a little bit is surges. So because it's on demand, anybody who's done anything on demand realizes that it comes in fits and starts. And this is the same thing with chat. So a physician can manage 2 chats simultaneously pretty easily, 3 chats, 4 chats even. But try 7 and your head's going to explode. When you've got 7 people that you're going back and forth, it can't be done. Quality goes down, there are safety issues and so forth. And the patients won't wait that long. It's interesting, we're finding out what their sensibility is around chat. And so if you don't reply in about 4 minutes, they think you died and went to heaven. They don't know what's going on. They expect things to be very fast. So we are going to figure out some sort of virtual waiting room. The serious folks hate that term because I think they think of like old Field and Stream magazines and like highlights or something, but we're gonna have to set realistic expectations about when you can get to the next provider. And obviously we want it to be as quickly as possible. So a little bit about what we've learned. We're learning about the impact on utilization. I don't know what's going on. So impact on utilization, we're studying 7-day post-chat utilization and trying to compare that to some of our other virtual care venues. It's a little hard to compare apples to apples because folks self-select into different care channels. But we'll need to track that. And so we're new, we've just been going since November, and so I don't have hard data to tell you, but it's looking good on that. We've learned about the maximum capacity of physicians, and I will say that there's a lot of individual variability. Some folks really like max out at 2 or 3, and some folks seem to handle 5 with Panache. So 4 seems to be about the average. You wouldn't want to push folks to do more than 4 simultaneous chats. We've had some interesting learnings about the skill set of emergency medicine versus family medicine docs, and of course, some more experienced docs seem to do a little bit better in the system. Now they know the system very well. They know how to write a work note. They know how to sort of access the 101 different things that the KB system can do. And then I alluded to this earlier, satisfaction is linked to resolution. So your ability to take the member quickly and get them an answer to the problem that they're trying to solve, the percentage of resolution is going to be very tightly linked to the satisfaction with the service. Of course, we're trying to teach best practices in communication. It's been interesting to me. I've only seen one presentation about this, about best practices in telemedicine etiquette. I'm surprised there is not more discussion about this, and I'd be fascinated to see what folks are learning. One thing that I think is really amazing is that within chat, we've been able to establish rapport, and I didn't think that we really would be able to do so. It's been very surprising. And because you don't have the visual, and you don't have the voice, and you certainly don't have the touch and sort of sense of what the physician is like. And yet, what the patient seems to do is project their best idea of a physician onto your words. And you say things like, "Oh, geez, I'm sorry to hear that you're feeling so lousy. You've really struggled with this cold for a long time." They think you're just like the nicest person in the world. I mean, you could be sitting there rolling your eyes, but they really do give you the benefit of the doubt. Or I don't know exactly what's going on there, but it's a fascinating thing to continue to study. Obviously, QA is a piece of cake. There's no doubt about what was said, what was asked. You can look at the full text right there. I'm running out of time. Some of the pitfalls that we're finding is that this functions sometimes as duplicative communication, and there's problems that they have to work out with that. So they'll email their doc, and 2 hours have passed, and they still haven't gotten an email back, and they're impatient. And so they hop on chat. And then there is a certain phenomenon when you lower the barrier to care low enough, you're going to start getting very low acuity issues. So, you can imagine minor stuff. I had a guy who came on and was like thinking about trying probiotics. Great. What are you going to say to the guy? But he would never have, waited in a waiting room to tell the doctor he was thinking about trying probiotics. That seems to be a very low percentage. We call them sort of subclinical, and it's very low. What do we think is going to happen in the future? It's going up. People want to communicate by text. You all showed that earlier. We need to meet patients where they are. This is where the future is going. I can tell you I was a skeptic. I can tell you I'm a convert. Folks will trust it. Folks do like to do it, and it is effective. I see us bringing in more specialists. As our volume grows, we will be able to justify having dermatologists, ophthalmologists, ortho, and so on to answer specialty questions. I think this will become the standard of care. And obviously, I can get into this AI and natural language processing, which we hope to start integrating into it up front so we can start sending these chats to the right places. And then, of course, biometrics, which run out of time. So thank you very much. Please send comments or questions.
Thank you, Ari. Excellent presentation.